Hey guys, welcome back to the Fertility Confidence Podcast. I am so excited to be back in front of the microphone. I know we released an episode last week. I actually meant to get this one out before, but it has been a fall. It's been a fall, y'all. I don't know if you guys can relate to this, but I feel like I have just closed my eyes and blinked. And August, September, and now almost all of October has gone by. And I know from talking to my team and from talking to clients and patients that I'm not the only one feeling this way. That time is quite literally just flying by. And I also want to take a second and acknowledge that if you do feel that way and you are on your fertility journey, which I'm assuming you are if you're here listening to this today, I'm sending you lots of love because we definitely want to pause time, right? We just want time to pause. We don't want to watch that time going by. And as we transition seasons and as we see the calendar flip, as we get closer and closer to the end of the year, I know how incredibly challenging and difficult that can be from a mental, emotional aspect on the fertility journey. So as much as I make jokes about how quick time is going, I also know that every time I say that out loud, I also send a little virtual hug to all of my fertility warriors, because I know that is quite literally the opposite of what we want to be happening. And it can feel very heavy, very, very hard as we approach this kind of last quarter, these back pieces of the year here. So that is not what we're talking about today, my friends. We are actually going to focus on our partners today. We are going to have a little sperm conversation because I keep getting asked very similar questions inside Instagram, in my DMs, in my emails, in Be Hormonally Confident. And we are going to do things a little bit differently. And I'm actually going to dig into some numbers today. And I'm going to share with you how we want to be reading your semen analysis. So if you are at home, if you are not currently driving a motorized vehicle, if you are at home watching this or listening, or you're watching it on YouTube, and you can just take a second, pause, and get the paperwork so we can actually go through it together. Now is your time to do that. If not, don't stress about it. Just come back, jot some notes down, come back and listen when you have that paperwork. If you are catching this over on our YouTube channel, I'm actually going to share the chart on my screen there. So if you're listening to this audio style on the podcast and you want to actually see the research paper that I'm going to talk about, you can do that over on YouTube at Dr. Kelsey Duncan ND. If you search that, and I'll throw the link in the show notes for you as well once we get that up there. But we are going to talk about male fertility, okay? And it's so incredibly important. I've had countless conversations with colleagues and health coaches and people in the wellness space where I've been asked repetitively, what is something that people often don't think about, don't talk about, or kind of gets pushed aside in the fertility journey. And quite honestly, I think a lot of the answer to those questions is male factor fertility. And the reason for that is first and foremost, we get very hyper-focused on the person with the uterus, being the one that actually has to get pregnant. We put way more responsibility, way more ownership, way more blame, way more stress on those shoulders. And we do it to ourselves. There's no shame in that, you guys. We all friggin' do it. Don't worry about it. And we get that sometimes from society, right? We get that from social media. We feel a lot of that pressure. And our partners often maybe don't have the same weight on their shoulders. And I don't want to generalize. I know that's not true for all partners, for all husbands, for all men, for all sperm people. But it is, pretty common. But the reality is that sperm is 50% of the equation, okay? A sperm and an egg come together to make an embryo. You can't make an embryo without sperm, and you can't make an embryo without an egg. So we don't want to just focus on egg quality. We don't want to just focus on uterine health. We want to have a whole body approach, which is a topic for another time. But we also want to make sure that we are driving home the sperm quality aspect of things and how incredibly important it is. 30% of infertility cases are driven by male factor infertility. So 1/3 of cases are driven by male factor alone. And then another 30% are driven by a combination of male and female. So that means 60%, over half of infertility cases, have some male component to it. So if you are early on in your journey, or maybe you're not even early on in your journey, but your, partner maybe has gotten like the old check mark, you're good, don't stress about it, I highly, highly, highly recommend getting a second opinion or getting that testing done for the first time. And the reason for that is that I can confidently say about 75% of the couples that we work with who have been given a green light, who have been told that there is no issue with sperm, when they come in and work with us inside Fertility Confidence Method, we actually say that's not true. We say, I understand that was the conversation you had with your doctor, with your fertility clinic, whatever may have you, but we hold higher standards here. And in fact, there's a lot of areas and room for improvement in what we're seeing in your numbers. This is why, and that's exactly what we're going to talk about and show you today. And then we bring that into the plan. So if you have been considering FCM, know that we don't just focus on you. We definitely look at both sides of things. And even if your partner's been told it's not a sperm issue and they can rest easy, like I said, I can almost guarantee you that that's actually false news, and we want to dig a little bit deeper. I will say there has been the odd time where I can actually tell a couple, like, sperm looks good here on paper. However, a semen analysis does not tell the whole story. So there's always room for improvement. Now, what we're seeing from a number standpoint, I'm actually going to scroll up on my screen here because I have some legitimate data. Now, this study that I'm referencing is old. I want to just be really upfront and honest about that. It's from 1992. As far as I know, and if there are any practitioners or anyone who's come across this, if you have a more recent picture of sperm concentration decline outside of this BMJ article from 1992, I would love to see it. Please pass it along. But basically, this is what we reference when we're looking at sperm decline. So what we see between 1940 and 1990, so we're talking like, a decent amount of time ago, that the average sperm concentration has actually decreased from 113 million per milliliter to 66. Okay? That's drastic. Like, my math is bad. That's almost half. Like, that's almost a 50% decline if I'm not 66 of 6120. Yeah, like almost. Okay. We've also seen semen volume decline from 3.4 mils to 2.75. Not a huge decline, but it's still there. We know that when giving a sample, the nerves and stress of that also impacts volume. And there's not a lot of studies on how semen volume actually impacts fertility. But my personal opinion is that I always tell my clients this and they kind of get a good gag out of it, but volume matters in terms of force, right? And the actual force of ejaculation is important because the sperm has quite a long road to get to where it needs to go. It needs to find the cervix in the vaginal canal. It needs to find the teeny tiny little opening. It needs to get through that opening. And then it needs to get to the back of the uterus on either side to find the fallopian tube and get all the way in and through there. Like, it is a quest, okay? It's not simple. It's not easy. It's why concentration needs to be really high. It's why motility needs to be good, because in all honesty, most of the sperm can't make it. They don't make it and they don't have the resources to do that. And if semen volume is low, the actual force of ejaculation is going to be impacted by that. And then the actual count of available sperm is going to be impacted, because remember that concentration matters with volume, right? It's million per milliliter. And we ideally want 2 to 5 milliliters from a volume standpoint for an optimal sample. So we are I'm going to get into the numbers, but volume does matter, and we are seeing a volume decrease, okay? And then we're seeing a count decrease by over 50%. And this is back from 1990, okay? This is 1940 to 1990. I feel pretty confident that if we saw 1990 to 2022, we would see an even further decline. And something that I want to just point out here before we actually get into the numbers is that what we're looking at when we're looking at a semen analysis is we're looking at reference range. Who sets the reference range? Who actually sets it? WHO. So who sets it was a question, but it's actually who that sets it, the World Health Organization, okay? And the last time they set reference range for semen analysis was back in 2010. So not that long ago. I'm assuming they'll probably do it again at some point. But they set the reference range based on population average. And this is true for all blood, like all labs, okay? Any labs that you have drawn when you're going to check your thyroid, when you're going to check your estrogen, whatever that may be, even like pre-fertility clinic days, you'd go for your like annual blood work and make sure that your iron is good and your cholesterol and all those things. And then we see, okay, everything is good, there's no flags, and it's within this range. That is just population average. It has absolutely nothing to do with what's optimal in your body. And this is a really big factor when it comes to optimizing your health as a whole and optimizing your chances of making a baby. And the same is true for a semen analysis. We're looking at population average, okay? We're looking at it from 2010. Not that long ago. Again, I'm sure actually that it would go down, unfortunately. Now, the other piece, and like I said, if you pop over to YouTube and subscribe while you're there, you'll actually get to see this chart up on the screen. But what you'll see is they show us volume, number, concentration, motility. They break motility down a little bit for us, and they show us normal percentage, so morphology. So the big numbers, okay? Volume, count, concentration, motility, and morphology. And we will see a bunch of different percentiles. So what that basically means is that let's start with the 50th percentile. If your numbers are within the 50th percentile, it means that 50% of men in this study got their partners pregnant within 12 months. Okay, so 50% of men who had a concentration of 73 million per milliliter got their partners pregnant in under 12 months. 50% of men didn't. Okay, so that's something that I want you to remember. Now, when we're looking at reference ranges and what the reference ranges on your semen analysis per clinic or wherever you got that done is we're typically seeing in the 5th percentile. So some clinics, I've seen a lot of clinics blood work pages and semen analysis over my days. Some are a little bit different, but for the majority of analyses, we're seeing about the 5th percentile. We're wanting concentration above 15 million per milliliter. We're wanting motility typically above 35% is what we want to see. So 30 to 40 usually is what we see. And we want morphology above 4%. So if we're looking at those three numbers specifically, we're actually looking at between the 2.5 and 5th percentile. So what that means, let's say your partner has a concentration of 15 million per milliliter. You're not marked as abnormal. You're like right on that cutoff of the reference range on that lowest level. Your clinic is going to probably tell you all is well, but you're in the 5th percentile with that level. And that means that 95% of men who had a sperm count higher than that in order to get their partners pregnant, meaning basically that there's a 5% chance, right? If you could have a 50-50 chance or a 5% chance, what option are we going to choose? We're going to choose a 50-50 chance, right? Because there's already other factors. This is like one teeny tiny piece. There's a lot of other factors at play. And if we can optimize concentration, motility, and morphology to give a 50-50 chance, then all the other pieces of the puzzle that are taking that percentage chance lower are still leaving you with a half decent opportunity, right? So when we're looking at levels, when we're reading it directly off the paper, we're looking at population average, we're looking at really low standards, 5th percentile standards, meaning that there's 95% of men in this study had better levels than your partner if they're on the cusp of those reference ranges. When we work with clients inside Fertility Confidence Method, we are aiming for 50th percentile. We are aiming for 50-50 because at the end of the day, we want to make sure we're doing absolutely everything within our power to make a baby. And if there is some area of room for improvement when it comes to sperm health, you better believe we're going to advocate for that to be happening. So when we talk about concentration, your clinic is happy if it's 15 million per milliliter or higher, meaning if you're a 20 or a 25, they're okay with that. You're now sitting in the 10th percentile. Not awesome. Better than the 5th though. But ideally, we'd actually be seeing sperm concentration higher than 70 million per milliliter. And that's a really big difference from 15. Truly, truly, truly is. And it seems outrageous that we need more than 70 million sperm per milliliter to have a 50-50 shot, but that's the reality when it comes to the torturous journey that is sperm finding an egg. Sperm don't do their job very well. That's why we need a lot of them. And that's okay. Unfortunately, that is the way the system was built. So concentration is a really big one that I personally struggle with when we're working with clients that are like, oh yeah, my husband, they said that everything was fine with him and it's totally a me problem. And then I look at the numbers and I'm like, okay, that's awesome, but we could do better. And we're going to do better because A, I want them on the journey with you so that you feel supported, and B, God forbid, another year goes by and if we had worked on concentration sooner, it actually maybe would have sped the process up a little bit. Let's not leave that be. In fact, this is a really good opportunity actually to segue into a story that greatly changed the trajectory of how I practiced. And it was my first year of practice. Was it my first year of practice? It might have been my second. I was a very early new practitioner. I was dabbling in fertility, okay? I was coming out of school. I was feeling called to working in fertility, but I was nervous. I wasn't quite sure. I wanted to keep my options open. So I had a more generalized women's health practice. I saw, PMS and period care and thyroid and stress and gut health and a whole slew of things. So I was working with this fertility client. She became a dear friend of mine. And we spent a whole year together, and there wasn't a lot of things in her blood work. It was one of those things where I was like, everything looks okay. We can do better here. We had to work on some thyroid. We did some gut health. We did a ton of acupuncture. She had a little bit of a longer cycle. We did the things. She then got into the fertility clinic, and we found out that her husband actually had no sperm. And it turned out that he had something that happened in his childhood that, I didn't even think to question about, and nor did I ask for him to get tested, and they had to do IVF. It was their only option. They now have beautiful twins at home. All was good. It worked great. If I had asked the questions, if I had requested a semen analysis, if I had have done things differently, we could have saved an entire year. And that exact moment where I personally felt responsible for mismanaging the case has completely transformed how we offer care to our clients inside Fertility Confidence Method and inside our Ontario Virtual Health Clinic Cared For Wellness, okay? Because we can do better. And male factor infertility is a very big piece of the puzzle that we can't be ignoring. So I want you to look at concentration. Then I want you to look at motility, okay? Typically, we want to see a total motility from a reference range perspective of about 35 to 40% is what we usually see. That's in and around the 2 to 5 percentile. For me, I personally like to actually focus on progressive motility. That means that the sperm is actually moving forward. If you have ever seen a video of a petri dish full of sperm, it looks like a circus. It actually looks like a circus. They're just swimming in all these directions. They're bumping into each other. They're bumping into the walls. Some of them are just doing these itty bitty tiny little swirly circles. And you're like, what the hell? How does anything productive happen here? So when we're looking at motility, when we're looking at the percentage of progressive motility, we're actually talking about the ones that are more so swimming forward. Those are the ones we want, because the suckers swimming in circles, they're never going to find the surface, ever. They're just never going to do it. And again, that is why we need so many of them, because a lot of them honestly swim like they're drunk, which is kind of like the running joke, right? So we want to look at progressive motility. Ideally, we want progressive motility to be over 45%, and that is a little bit lower from like a percentile standpoint. We're talking, in the 25th percentile. But I feel from the just clinical experience side of things that seems to be a pretty decent level. If we can get it up over 50%, I'm very, very happy with that. If we can get it over 60, even better. So that's what we're looking for from a progressive motility standpoint. Then when we're talking about morphology, if you haven't had your morphology tested, I highly recommend it. I think it's probably the more misunderstood factor when it comes to sperm health. Some clinics don't even run it. Some clinics really don't care about it seems. It's a bit of a joke in the company that I feel like there's this reference out there that talks about morphology and how, it really isn't a big factor in pregnancy, that I just haven't seen, because sometimes I feel like decisions are being made based on morphology that make quite literally no sense to me. So I'm still on the hunt to really fully understand and grasp this concept. But what we see from a reference range standpoint is we would like morphology to be over 4%. I know that sounds low, and the truth is it is low. That means that if we are looking for 4% normal, that 96% of sperm are abnormal. They either have misshaped heads, misshaped acrosomal necks, misshaped tails. They wouldn't actually be really viable sperm. This is yet another little asterisk to say that concentration is so important, because a lot of the sperm aren't good. So we really want to make sure we have those high levels. Now, from a optimal standpoint, if we were going with the 50th percentile, we would actually want morphology to be about 15%. This is where I pull in my clinical experience, because if I'm being perfectly honest with you, I have very, very, very rarely seen morphology over 10%. I would say between 4 and 10 is more in line with what I like to see optimally. And to be truthful, because I think it's always good to be transparent, this is the one parameter that I'm just truly happy if it's 4%. If it's 5, I'm celebrating, and people will be like, oh my God, but it's so close to the cutoff. And I'm like, I don't care. Concentration, I care. 20 million is not enough. I want that to be higher. When it's morphology, if it's a 5, I'm like, woo, we're above 4. This is awesome, because it's so common to be below 4. This could definitely be, a topic for another day, but I feel like there's likely a lot of environmental factors at play here, and our general kind of like health risks in terms of obesity and diabetes and insulin resistance and cholesterol and smoking, the oxidative stress and damage that comes along with that, and with inflammation, with being bombarded with our environmental toxins and chemicals and pesticides in our food. I'm sure we could pull in, electromagnetic radiation, and just the general difference that our day-to-day environment is now compared to 60 years ago is drastic, right? Not just what we come in contact with, but also the food we eat, our water quality. And that is likely a really big driving factor into why morphology has been declining so dramatically. And I will say that this year alone, it's 2022 when I'm recording this, this has been the most I've ever seen morphology of 0 in clients. It probably was years in practice before I had ever even come across that before. And this year, maybe it's just the clientele I'm attracting. I'm not sure. Obviously, we're working with more women. Our sample size is bigger. We're going to see these things more, and we're going to see more of the complex cases. But I am now finding this and diagnosing it more frequently. And we can talk maybe a little bit more about morphology and about 0% morphology and what I feel like that means versus what some clinics feel like that means. On another episode, because I want to just make sure we're focusing on the numbers. So let's just really quickly recap what are our optimal levels for semen analysis, because that is what I want you to take away from today. So optimal volume, we want over 2.5. okay? 2.5 to 5, but over 2.5. Optimal concentration, we want over 65 million per milliliter. Closer to 70 or higher would be amazing. I'm happy if it's over 40, but I want it to be better, okay? Progressive motility. So that might also be actually labeled forward progressive motility on your analysis. We want that to be like 60, 65. And morphology, we'd like that to be over 4%. And I'm going to give a little disclaimer here that there are some companies, some labs that actually run a different version of morphology than what the World Health Organization has used. And so their reference range is different. So that is not the same. And it will be very obvious because they'll actually usually say where their reference range comes from on the semen analysis. But I have seen some labs actually use their normal being above 20%. And I've actually seen some labs, their normal being over 70%. So there are some different variations out there. And right now I'm speaking to the World Health Organization circa 2010. And that's typically what we're seeing used here in Ontario, Canada for the time being. So that's where we want those numbers to be, okay? Like I said, we need to hold our sperm to higher standards. If you want a 50-50 shot at making a baby within a given 12 cycles, those are the numbers you want, okay? You don't want 15 million per milliliter. You don't want a 5% chance every month over 12 months. That's not okay. This is why we're so incredibly passionate about supporting male fertility inside Fertility Confidence Method. In fact, we actually actively work with and have had success with couples who only have a male factor diagnosis. It is incredibly important to investigate this side of things. And I shared that story where I was not investigating that side of things and we wasted time because of that. Even if your partner is super healthy, even if your partner has children from a previous relationship, even if you guys have a child from previously, even if you're dealing with secondary infertility, a lot can change, okay? Do not let that be an excuse to skirt by without evaluation. And I will say with the secondary infertility or kids from a previous relationship, I see that a lot where doctors will say, well, we don't need to test you because obviously you're fertile. And maybe it's been 2 or 3 years. Maybe it's been 10 or 12 years. That is enough time for things to change and enough time for things to change enough that it's actually a problem now. So do not let that be an excuse. Advocate for that testing, okay? And if you haven't had a semen analysis done, don't fret, okay? You're going to want to make sure that you save this episode so that you can go back, you can find that reference in the YouTube link so that you can go through and look at the numbers when you do finally get your semen analysis. But my rule of thumb is that if you're still waiting for that assay, for that semen analysis, always still treat like the numbers could be better, okay? Because the semen analysis numbers, the volume, the concentration, the motility, the morphology, it's only part of the story. They don't actually tell us that much about quality. We still want to work on things like inflammation and oxidative stress because that's what's going to help with the DNA integrity. That's what's actually going to help with the pieces of the puzzle that we don't see in that testing. And there are strategies that you can actually implement now while you wait to get these numbers, okay? And if you want to learn more about what that looks like, I highly encourage you to schedule a free clarity call. We can get to know you a little bit better, get to know your fertility journey a little bit better, and see if we can better support and help you out. And if we can't, if we don't feel like that's a good fit for you right now, we'll make sure we find you a resource to help you move forward in your journey, okay? So you can do that at www.kelseyduncan.com/clarity-call-application, and I'll throw that link in the show notes for you as well if you want to go back and check that out. So hopefully this was helpful for you guys. Like I said, I've recorded this on a video if you're catching this on the podcast, and I will throw the actual number chart up on the screen on YouTube. So you can go over to YouTube, Kelsey Duncan and Dr. Kelsey Duncan ND, and find this How to Understand Your Partner's Semen Analysis episode. And I'll make sure we link that in the show notes for you when we have it up as well. Take care, and I'll see you guys next week.